And thanks for that, that kind introduction. Understands, I don't know, exposed to, yes. But what I understand, I'm not sure, and what's understandable in our healthcare system at times, you wonder. But we've all been exposed to a lot of it, and it's really thrilled to be here with you all and spend some time talking about how we're thinking about healthcare, at least now at Trinity Health. So I'll make some comments, probably 25 minutes or something like that. If someone has a burning question, please interrupt, raise your hand, scream out, whatever, and let's have a conversation along the way, and there'll be lots of time for questions at the end as well. So let's see if this works. Yes? Building a people-centered health system together is our strategy, and the strategy that we talk about today and every day at Trinity Health and across our regional health ministries. I'm going to try and describe to you why we got to that strategy, what it means, and what we think some of the challenges are with it. Along the way, I'll touch a little bit on I'll talk a little bit about the background to healthcare, to the healthcare industry, what the dynamics are today. Talk about a strategy, and then I'll talk a little bit about what it's like to be in Washington, and would love to get questions or thoughts or comments about, how the DC world looks from where you all sit. And we can have some fun, perhaps going back and forth and talking about that. I'm not a long-term government employee, but I was there for 3 years, so it was very interesting. So let me start by telling you a little bit about our mission. Trinity Health, as it exists today, is the result of a merger that occurred almost 2 years ago now between Trinity Health, the legacy organization, and Catholic Healthcare East, bringing together organizations that had, with Trinity Health, large representation in the Midwest, a little bit on the East Coast, a little bit on the West Coast, with CHE, which had a great deal of representation organizations along the Eastern Seaboard. And when we came together, the boards had to first come together as a new board, and we took a number of folks, 6 folks from each of the existing boards, and then added 4 more folks to that. So we now have 16 members of our board. And over the last year, the last 2 years, really, they've really come together and started working as one board with one mission, vision, and strategy. And when they first came together, they worked hard to develop a consistent and a singular mission statement that they thought captured the legacy of their organizations as well as what they sought to become in the future. And this is it. We, Trinity Health, serve together in the spirit of the gospel as a compassionate and transforming healing presence within our communities. As we go along and talk about our strategy, and as I tell you more about that, I hope you will see how our strategy fits so well within this, and key words of being a transforming healing presence in communities, serving together. You'll see that those themes come through in our strategy. They also worked on developing a set of core values. And it is remarkable, and I don't know, so far I've met, I think, 10 people here, and I think half of them worked at Trinity Health in the past. So how many people actually have worked at Trinity Health or at Ascension? Right? So this is a remarkable representation of experience with Catholic healthcare. But this is my first experience, and it's amazing to think that sisters getting off boats or sisters getting on horses 160 years ago, 1, 2 at a time, 3, 4 at a time. Today, the result of their efforts is Catholic healthcare in America delivers 15% of all the healthcare in America. Pretty amazing. And as how many people have read, Jim Collins, Good to Great, Great to Good, and Better Than Ever, In Pursuit of Excellence. All those organizations that are identified as being great organizations the majority have come and gone, even over the last 50 years. And through that, across the last 160 years, now Catholic healthcare has continued to evolve and be successful. So it's a remarkable legacy that we live with, And the core values that kind of sustain that over time are important to us and continue to be important. And they are reverence and dignity of every individual, acting with integrity, commitment specifically to serve everyone, but also with a special focus on those who are poor and vulnerable, a sense of justice and pursuing social justice. And then, most remarkably, in some ways, when you think about that ebb and flow of organizations, the rise and fall of organizations, a consistent ability to be successful operators and effective stewards of resources over that period of time, that continues to be a critical piece of how we think about our work. And it will inform a piece that I'll talk about in a few minutes about how in healthcare we're facing not just the need to change the way we deliver care, but we have to change our business model, the way we get paid for care. And if you think about Catholic healthcare evolving over these many years, I think we could probably go back and look at the evolution of both the clinical model and the business model, and you could think about where we are today in healthcare as just the latest permutation in that continuous evolution of a remarkable organization seeking to serve effectively in as many communities as possible. So, as Brian mentioned, we're in 21 states, 85 hospitals. We are the fourth largest healthcare network, second largest not-for-profit healthcare network across the country. Very large home care agency. We're the largest provider of PACE services in the country with 14 PACE centers. We have 70 other continuing care communities ranging from independent living to skilled nursing facilities, about 3,300 employed physicians, about 23,000 doctors who practice in our facilities. So you can see that 85% of the care in our facilities and in our various care models, are provided by voluntary physicians. Very critical part of our work. And overall, we deliver about 1.5% of all the babies born in America each year. So it's a pretty broad network and a remarkable legacy. Let me take a step back now and give you context for why healthcare is changing rapidly. If you go back to 2009 and people talking about healthcare reform, these were the realities driving the perceived need to change the way we operated our healthcare system. One, uninsured in America, that was a number of people that did not have access to care that was equal to the population of England. Within our great country, that many people without access to care. Now you could say they can go to the ER, and they could, and we'd have to take care of them, and we did. But what we're seeing now is remarkable. Those folks who are going for episodic care, only for acute emergency care, we're starting to see now the results of expansion of care in our hospitals here in Michigan. Story after story of people who have put off care and now are coming to get the care that they need. So that was one big reality behind the drive to do something different in healthcare. Here's number two and number three. First, the quality of our healthcare system. What do we produce? And the remarkable thing is we have great people who are educated better than anywhere else in the world. They are committed. They're mission-driven. They went into healthcare for all the right reasons. They work hard every day and do a lot of stuff. And the result, remarkably, was a life expectancy that's way out down to the right here compared to other countries, right? That you can see on the blue columns, life expectancy along the way. This chart also demonstrates where we are with the total cost of care. How much does it cost to deliver care to each person in a country? And if you look at that, we were basically twice as much. So we were literally spending more, twice as much, for a shorter life. The cost of care, the quality of care, despite everybody's best intentions, the system produced outcomes that were not optimal, and we paid a lot more for it. And of course, that's what led to slides like this, the iceberg, the hidden peril of this enormous cost that's coming along. Why a big increase in cost? Well, I was out at our great airport. I spend a lot of time at the Detroit, Wayne County International Airport. And it's great. It's a beautiful place. They've got all sorts of places you go through security, and I get TSA pre-check a lot now because I'm traveling so much. So I go to the pre-check thing, and I'm about to step into the machine. I emptied only my pockets, didn't have to take my computer out of my bag. Very nice. But I go to enter, and this nice young man standing there, he looks at me and he says, "Any artificial joints?" I said, they're all original parts. Thank you very much. But his comment reflected, the iceberg. It's all those baby boomers coming along who are doing things like getting new hips and new knees. So that's out there as well. And so when people were looking at our healthcare system, we understood that we needed to address access, we needed to address quality, and we needed to somehow find a way of addressing the total cost of care that we were facing, because it had grown enormously. So those were the three big things that everyone, not just the administration, not just the Hill, but private employers as well, state governors clearly have been facing all along. The result of all their efforts has created a marketplace now that is demanding fundamental change in how we operate and what we produce. It's as if someone said to Detroit, we're all going to get around with helicopters instead of cars. Could you please produce something different? That's what it's about, because we know how to produce volume, we know how to produce services, we know how to produce a hospital care episode or stay. But when someone says to us as healthcare providers, please deliver better health, better care at lower cost for a population of patients that you serve, we kind of look at them and say, helicopters? Right? Because that's not what we produce, and that's not who we have been. We don't know how to do that. So we need to change. And what's driving that is, how many of you folks here have actually moved to a private exchange in providing health benefits for your employees? Many? Not many. How many are, anybody said, gee, go out and you give your employees a amount of money, a defined contribution, go buy your own insurance? Has anyone taken that route yet? Interesting. It is happening. There are not just public exchanges, but private exchanges where people, employees, are actually buying for themselves. I had a friend who was the head of a large insurance company sales team in Philadelphia last year, and she said to me, we sold 60,000 new contracts in Philadelphia on private exchanges, right? So there's a movement from the HR department choosing the coverage, the insurance plan, to individuals choosing insurance plans. And when that happens, as you all know, you got to have a value proposition that makes sense to your customer. And if your customer is just shifted from the HR department that says, I want a large network, I want every hospital, I want all the employees, because I don't want to have the headache of people coming to me and complaining that their doctor's not in the network, right? Which has been the typical case, the way healthcare is purchased in the private sector. And now we have individuals saying, I don't need a broad network. I need my doctor, maybe my hospital, in the network. This is a retail market rather than a wholesale market. The value proposition changes. Suddenly, we have to produce value in healthcare. So now you have insurers like Blue Cross here in Michigan saying, we want high-value networks that don't necessarily include everybody. And we've got to retool our factories to deliver value instead of volume. We're also having, as a result, people have larger deductibles. So before your child sprains their knee, you go to the doctor, he said, take them over to the hospital, get an MRI, never see the bill, cost you $30. Now, child sprains the knee, the doctor says, going to need an MRI, it's going to cost you $2,000 there or $300 there. Where do you want to go? Different world for us, right? Now we have to produce differently. And of course, there are financial incentives. I'll talk about that a little bit more that are driving this direction. So you may have heard people talk about population health management. For how many people is population health management a familiar term? Everybody. Okay, good. Well, so I came to Trinity. You know, I had a background in insurance and a background working in the government around things like population health management. And I said to our folks, well, you know, we got to become a population health management organization. After I listened for a little bit as the new guy on the job, tried to listen, go around. But we all talked about population health management. We have 89,000 employees. 88,750 of them looked at me and said, population health management, what's that? I'm in the business of providing acute care or physician office care or skilled nursing care. And so as we talked about it more and more, the leadership team, we realized that's not a resonating kind of framing of what we want to be and what we need to become to meet our mission. And so instead we said, we reframed that and we said, we want to build a people-centered health system together. Now, people-centered is a funny term. In the business world, we all used to think about this as, being customer-driven, being market-driven, understanding your customers' needs, building capabilities to meet those needs. In healthcare, we haven't been so good at that. And so it's actually necessary for us to remind ourselves, maybe we should design care around the way a patient wants to get care instead of the way we want to deliver care. It's about, 20, 30 years behind where American industry was back in the 80s and early 90s, right? Where they became market-driven and customer-centric, customer-focused. Well, we're still working to get there, and we actually need to talk to people about what it means to be people-centered. And I challenge you to think about an experience you've had in healthcare that felt extraordinarily different. Oh my goodness, this is the way I should receive healthcare. And think of other instances where you say, I can't believe they just asked me for the 4th time today what my address is. Right? Or what my insurance card is, And think about the proportion of those two experiences. And when I think and talk to other audiences about that, it's like the proportion is 1 to 10, maybe 2 to 10, right? And we need to find a way to become more people-centered. So we're talking with our folks about that a great deal. We need to be that way whether we're delivering episodic health care, whether we're managing populations in chronic disease, or whether we're reaching out to our community in new and different ways so that we can address vulnerable populations who need our services, or the fundamental underlying determinants of health in a population. Why do kids in this neighborhood have higher rates of admission for asthma, for example? What can we do about changing the environment in their homes to avoid those kinds of admissions? So that's an example of a fundamental determinant of health. So we need to work in that space too, and we are. All with a goal, going back to what the problems were. Our goal is measured, and our metrics, our measures of success, the numbers we manage by fall into 3 categories: better health outcomes, better care, a better care experience, and lower costs, lower total costs. That's the way we think about our business today. Now, some of these new, we need to build these new capabilities. If you were building a car factory, you probably don't make rotors for helicopters. But if you're going to build helicopters, you got to have a part of the factory that builds rotors, right? Well, we had to build new capabilities into our system to become an effective manager of population health. And so we are systematically engineering new capabilities to deliver better care to our patients. We have a care management model. There's a picture here of a young woman. Her name is Katrina. She lived in Muskegon. And this is her daughter, Kataya. And Katrina was a high-risk mom who was pregnant with her 2nd child, multiple chronic diseases, homeless, not eating enough. If we did not have a community health worker that identified her and sought out care for her and helped her get a new home, and helped her get regular food, she would not have the healthy baby Keziah is. But as a result of the intervention, she actually had a healthy baby. That's a great example of the kinds of interventions and the outcomes we're looking for. We have created multiple accountable care organizations that take responsibility for delivering great care and that triple aim of better health, better care, reduced costs to populations. We now have them in 27 states, in 21 markets, 27 altogether. And we built a new IT structure. If you want to see who's in the hospital today, you need an IT system that shows you a list of people, right? But if you want to figure out who in a population of 100,000 people would benefit from a care management intervention, you need a different IT system. One that gathers up all that information, identifies for your nurse care managers, who you didn't have before and you have now, who the people are that they should pay attention to. So we're building those enterprise-wide capabilities today, and we've done it in a variety of ways. We're also in the bundle payment business, where in the past, you have a hip replaced, you go in, the hospital provides the service, the doctor does the operation, hospital sends a bill, Medicare sends a check, here's $25,000, thank you very much, done. Oh, and you go to a nursing home, or you go to a rehab hospital, or you go home and get home care. The hospital had no vision into that downstream care. Great example, Partners Healthcare in Boston. They do a lot of orthopedic surgery, right? Great place. And they send people out to nursing homes afterwards. How many nursing homes do you think Partners in Boston send patients to? Throw out a number. Anybody? I'm sorry? 30. 500. 500. Never knew. Had no idea. Never seen the data, right? Then there was a program at CMS where we actually gave them the data and said, here's all the experience of your patients, not for just that episode of care, but for 90 days. I'm sorry, not for just that stay in the hospital, but for 90 days afterwards. And suddenly, the CEO of Partners Health looks at it and says, oh my goodness, how can we provide coordinated care when we're sending people in 500 different directions after they leave here, right? No visibility into that in America. So now we say, here's a deal. We'll pay you for 90 days, all the care, all in. You're at risk for that. Give great care. And by the way, if today that patient is readmitted, we'll pay another $25,000 because you had an infection. We'll take it out, put a new one in. You bill Medicare, they pay another $25,000, right? Under an episode of care system, you get one payment, in effect, right? And you're at risk for whether or not that patient develops a complication. The game has changed. Now you have to deliver better health, better care, reduce costs for individual patients. So we're doing that in a bunch of places. We've put together what we call a clinically integrated network. Sorry. Let me go back for a sec. Called Together Health. This is across Michigan. We found that together with Ascension, we actually covered a whole bunch of Michigan. And so we put together clinically integrated networks. Our doctors, our medical staffs, along with our hospitals, put together networks that were willing and are willing to assume responsibility for care for populations statewide. So that's a great example of the new kinds of things we're doing. We also formed a joint venture with an organization called Heritage Provider Network from California. These folks have been taking risk for populations of patients for 30 years. And so rather than try and build all the capabilities de novo, starting from scratch, we decided to do a joint venture with them and begin contracting in a new way so that we could deliver those outcomes for populations and get paid for it at the same time. So those are some examples of some of the new things that we're doing. Our overall strategic plan we call People-Centered 2020. 5 focus areas. 1, people-centered care. We have to change the clinical model in how we deliver care, and we need to change the business model. So while we have people re-engineering the way we deliver care, we have people contracting with insurers across the country in new and different ways. Instead of just paying us per acute stay in the hospital or per doctor visit, we say, how about if you tell us what it costs to deliver care for this entire population of 100,000 people, as an example, and we'll take risk for that. We'll be responsible for delivering that. If we save money and we deliver better care and we meet your quality and experience of care goals, then we get to keep that. And if we go over that amount of money, or if we don't deliver great care, we'll be at risk for that and we'll be responsible for it. So that's the notion of changing the way we deliver care, changing the way we get paid for care. We're also doing a lot of the bundle payments approaches, episode of care approaches that I described. We know we have to focus on engaged colleagues and help colleagues understand what does it mean to operate in this new way and what does it mean to be people-centered. So we have a bunch of initiatives there. We have several initiatives to develop operation or to really improve the operational performance of our organization. if you think about places like Trinity Health or Ascension or HCA and a lot of these big national networks, they grew often by accretion. Like, you find another set of hospitals that want to come in and be part of you. And then you grow, again, another set to be part of you. Well, it's kind of like a coral reef. Over time, if we started with one sister tending to one patient, today, between our patients and our boardroom, we have 89,000 people with all sorts of care processes and administrative processes that had never been designed to deliver value at scale. And so we have to re-engineer our core company all the way through those processes of care, and that's what that's about. Our board is very interested in being a leader nationally, and at a time when things are consolidating, and a lot of independent hospitals are looking to become part of larger systems, we know that there are great opportunities to expand and grow, and we believe we need to grow. And so we are responding to those opportunities. We made an announcement recently that we're adding a new system in Hartford, Connecticut, as an example, and we have lots of other things going on. And lastly, we need to we have a set of initiatives that allow us to be effective stewards as we go through this transition. And you can imagine, if you used to get paid that way, and deliver care that way, and now you say, how about you deliver care in a way that avoids complications, that avoids readmissions, that avoids doing the very things that used to be the basis for your model of the way you got paid and the way you existed and survived? You need to be very mindful of the financial aspects of that new environment. And that's why we have a set of initiatives focused on stewardship. So if you think about it as a purchaser of care, I ask you to think about this as many of you fund employee benefits programs. How many of you are self-funded? Any large organization, your health plans are self-funded, right? Yeah. Well, I offer this specifically, particularly for you all to think about, because if you think about that, in the old world, the producer-centered world, the cost of care is going up at this rate, right? And if we're right, and that if we deliver care differently, a people-centered care approach would produce care at a lower rate, then there's going to be savings, right? We're going to deliver savings, and we called it here the population health dividend. Now, if I'm an insurer, if I don't have a contract to give you part of that dividend, I say thank you very much. And I go and I either deliver lower rates to my self-insured employers or my large employers. I put more money in the bank because my margins have gotten better. And is anyone here from Blue Cross? I guess I should ask that question. Oh, there you all are. Okay, right. You call me up and you say, hey, costs are lower this year, here's some money, right? Now, I must say, as a Blue Cross guy, as an insurance guy at Geisinger, I never made that call. I'd like to have, but I didn't. At any event, we need to get part of that dividend, right? That dividend needs to be divided up and go to a couple of different folks, right? It needs to go to insurers and large employers. You need to get your share. You need to get lower costs. It needs to go to patients. They didn't want to pay less. But we also need to get some back to invest in care going forward, because it costs more to provide this kind of care than what we have been doing traditionally. So we need that dividend reinforced. So on to Michigan for a moment, and maybe you all know this, but it seems to me that there's a real opportunity to make a difference in Michigan by investing in these population health management opportunities. Now, I'm not going to say anything about the roads. I guess you already discussed the roads in Michigan today. Although I did hear an interesting statistic, like from Gray, as we were coming in. Where does Michigan rank in the dollars per capita spent on roads? I'm sorry? 49th? 50th, right, yeah. What is it, $128 versus $250 average, something like that? Yeah, some of them as high as $400. And those are roads, those are states that don't have salt to put on it somewhere between 6 and 9 months of the year, right? Like New England or Pennsylvania. Anyway, the truth is health status has a ways to go in Michigan. You have great opportunities. We can work together to address these challenges, I believe, across the state, and it's meaningful. We're making giant investments in Michigan. I was out at Chelsea visiting our facility there last week. And as I thought about the investments we've made, in particular in Southeast Michigan, it's remarkable. Giant investments in Livonia, in St. Joe's, out in Oakland, a whole new hospital tower, redo of St. Joe's in Ann Arbor recently, and Ann Arbor and Chelsea, beautiful facilities. So we're committed. We want to work with you all. We want to do this kind of new care models together. And we have almost 500,000 Michigan residents now in our different ACOs, or accountable care organizations. So we're doing lots. That's Southeast. We're doing lots in Western Michigan. And we're very excited about the opportunities to make a difference with you all in Michigan Health. I've talked about Together Health as a major effort on the part of Trinity and Ascension to try and do that. So we'd love to do that together. All right, so let me talk about Washington for a moment. And so I was working for Geisinger, actually, and then got an opportunity to go work at CMS about 4.5 years ago now, I guess. And Gray reminds me that sometimes people wonder about what it's like to be in Michigan. I mean, in DC. And for someone coming in from the outside, the remarkable thing, and I always use this notion, it's a really windy city. I mean, Chicago's windy. Yesterday in Detroit was very windy. But DC is windy conceptually, because what happens is you think you're going there. You know, you say, I'm going there. I'm going to do this. We're going to do this work, right? Well, you've got incoming from every direction, literally. You've got, a headwind blowing from industry, right? The headwinds are always there because the truth is there's a lot of people like status quo and just soon not have change, right? In any industry, it doesn't matter. So you've got these enormous headwinds coming at you. You've got people on the hill, two sides, who believe they know what's right, or, as often, don't even care what's right, but think about what the political opportune thing is to do. So you got wild crosswinds. You'd like to have a tailwind from, down the street at the White House to kind of help you going, but they're responding to some of the same pressures too, right? And so the result is, you think, you have great ideas and you have smart people with good ideas, and they put them down on paper, and then you say, well, let me get this good idea out into regulations, right? Which is what DC produces. DC is, it's interesting. It's a transaction town. It's not a results town. I mean, aside from elections. Elections are the results, right? But in terms of results that we all as business people or mission-driven, not-for-profit organization people, we have outcomes we think about. And DC doesn't tend to have that. It's transactions along the way to dealing with the political reality. And that's not to say transactions in terms of people putting money in each other's pockets. It's not that so much, although there are campaigns, obviously. But it's transactions in terms of taking one step at a time and knowing that things are moving along. In this environment, it's really important to kind of stay focused on actually getting the next thing done that needs to get done. So if you come into this and you're trying to execute a specific agenda, like creating accountable care organizations or creating bundle payment programs, here's what happens. Somebody has a wild idea. There's legislation, 2,000 pages of the Affordable Care Act, and in that there's a little section that says, a page and a half says you should create accountable care organizations. So you get to town and someone says, well, what is an accountable care organization? Everybody says, I don't know. Guess we'll have to figure it out. You write a white paper, and then you identify 10 different issues to create an accountable care organization. And then you expand that a little bit more, and now you're working in a group of 5, right, at CMS. And then you take it to the higher-ups within CMS, and you say, well, you develop it further. Oh, no, I think this, I think that. 27-year-olds who have never been in healthcare think, this is the right answer, right? This is within CMS. You go through all that for a few months. Then you go before the administrator. And now in the administrator's office, you got Don Berwick, great leader, great thinker. You got the head of Medicare. You got the head of Medicaid. You got the head of the duals office. And around the room, you've got another 30 people sitting on the windows, along the windows and on couches and top of couches and standing up, tossing in opinions about what they think the right answer is. You got the staff who kind of goes, okay, I'll go rewrite it again. You got a decision paper now that's ready to march through HHS, the Health and Human Services to end up at the Secretary's office. You go through a whole clearance process in which you have another series of 7 or 10 meetings at which another set of 30-odd people varying in age from 25 to 70 who have been around CMS for a long time that have ideas that remember what we tried to do in 1980, right? All these people weighing in with ideas and suggestions. And you take it back and you kind of rewrite it all again. And then you say, okay, you take it to the Secretary's office, and she says, okay, that's good. Then it goes to the White House. And at the White House, you got OMB, you got the Domestic Policy Council, you got other departments in the administration, and they're all weighing in. And the remarkable thing is, out of all this comes something that becomes law. And more often than not, you know, it's within a range, but more often than not, it's almost good enough. It's almost good enough. That's the way the process works. Then, of course, it gets out there. It's on the street. You publish a reg. Enormous response. Everybody says, oh, I can't believe you're that stupid. I can't believe you thought that's what we meant. Don't you know that this is impossible? That happens. It all comes back in, and you start over again. And you go through it again. And you go through all those steps again, and it comes out 6 months later, and now you have a reg. That's the way it works. Of course, along the way, I'm having meetings. We're all having meetings with every organization that wants to weigh in because you have to hear what they have to say. You're going up to the Hill and hearing their input. You're hearing input from the Senate, the House, from the Reds, the Blues, everybody. And the remarkable thing is, out of all that comes something that's not too bad. It kind of works. And then we all adapt, right, to it, and we start figuring it out. So that's the process, and there are a lot of challenges with that. But I must say, I come away very hopeful that it's actually, while on the surface it's no way you would design any sort of a decision-making process, when we need the government to get involved in stuff, it comes close to getting it right enough that we can live with it, I think. That's my conclusion. Happy to see what you all think. In all that time, we heard from folks in the industry. Can't you just set a strategy? Can't you just tell us what the timeline is? When do you want us to go from building cars to building helicopters? Tell us by X date when we're going to be there, because otherwise we got a foot in both canoes, right? We got one on the dock, one on the boat, 2 canoes, whatever. We're confused. We don't know. We can't plan. We're business people. We want to plan. So everybody, many of you probably came in and said, can't you just give us a timeline and give us a strategy? Well, the reality is the answer was no. Because for all the reasons that Washington operates the way it does, the judgment was that that was not the time to lay out a timeline and say, this will be the case by 2020, right? We're going to enforce a transition or something like that. There was a decision made not to do that. Well, that all changed about 2 months ago. Secretary Burwell said, we are setting a timeline, and we are telling you that CMS is going to change the way it pays such that 50% of our payments will be in accountable care organizations, bundle payment programs, medical homes that are accountable for delivering the total cost of care. 50% of all our payments will be there by 2018. Then, last week, the White House sent out an invite to a lot of people in healthcare, and saying, come in, please come. You'll be joined by a senior White House official and the secretary to hear about our plans for this transition to a new value-based system. It turned out the senior official was the president. By the way, before we got there, we were all standing on a sidewalk waiting outside in a light rain. It was about 32 degrees. And if you wanted to hit the reset button on American healthcare leadership, you just drive up about 3 buses to the sidewalk, escort everybody on the sidewalk into the buses, take them out to Virginia someplace, whatever, and call the next generation in, because providers were there, payers were there, folks from Blue Cross Michigan were there, consumers, educators, employers, and patient advocates. Everybody was there to hear the story. And the story was from the president, I'm paraphrasing, you payers, pay these providers differently because we want them to produce better health, better care, and reduced costs. We want them to change their business and their clinical model. Get on it now, let's go. That's what the president said. That's what the secretary said as well. So there's also a national group that we are part of called the Healthcare System Transformation Task Force. And we are similarly, we've set a goal, and we've said by 2020, we will have 75% of our business operating through those new models. 75%, in effect, producing helicopters. So we've got a bunch of providers, payers, and consumer and employer folks on that task force, and that's working hard in an aligned way. So I know there's great stuff going on, and there has been a lot of work done in Michigan already. You've got these great initiatives, Healthy Michigan. You've got the MyPick program where you've been changing the way primary care is reimbursed. You've got the Physician Group Incentive Program, PGIP, where the Blues have been very progressive. I guess I should say Priority has been very progressive in that regard, so I'm an equal opportunity kind of guy. But other insurers have been there as well. But you've been very progressive at driving towards this transformation. We're stepping it up now, frankly. I think we're going to have to step it up. And I hope that as part of the state innovation model, which is another one of the models that came out of the CMS, where we're working, we had this vision of governors sitting down and saying, okay, all you insurers, all you providers, all you patient advocates, all you large employers, come to the table and let's agree on how we can transition our healthcare system towards this future vision of delivering better health, better care, and lower costs for our population. You are a giant player in that state innovation model space. There's a number of states. I forget how many it is. What is the number? Is it 16 states overall that now have big money? And I think Michigan has, what, $70 million? You all are the leader, I think, just about the most money of any state. That is, I'm sorry, number 2? Yeah. To help this transition occur. And it can occur. And it's so much better for this to happen through the private sector and through the states than to use that process that I described in DC. We want to use that as little as possible, right? What we really need is to figure out how to do this in our local markets. And so I think it's great that we are in a place where we can do that. We're supported. I know the governor is really committed to that. And I look forward to working with our team. And I know our team looks very much forward to working with you all in trying to make that happen. Thank you very much. It's great to be with you all. Questions, Ed? Sorry. Questions, comments?
Clark Ballard with the Michigan Health and Hospital Association. Dr. Gilfillan, you mentioned Trinity Health is a not-for-profit healthcare system. We're seeing an increasing presence in Michigan of for-profit healthcare systems. Could you talk a little bit about for-profit versus not-for-profit healthcare?
Sure. Well, I think it's a great dynamic. I think I've kind of been in both worlds in my past lives. I think it's a great dynamic. I think there's no question in my mind, and I must say that as being part of Catholic healthcare that is so strongly mission-driven, we bring a different perspective, a different approach, and I hope over time more added value and leave more added value in the marketplace than the for-profit folks do. But in a good functioning marketplace, you know, we'll compete head-to-head, and I think that the environment is such that everyone is going to have to demonstrate they can produce value. And so I think it's incumbent upon us in the not-for-profit sector to demonstrate that we can provide more value to communities than folks coming from the other side. And that'll be different in every market. We'll figure out how to compete. We'll learn from them. They'll learn from us. And, you know, at the end of the day, in a healthy market, it will get resolved. And we are focused on whipping them and having fun doing it. Yes?
Hi, Tom Simmer from Blue Cross Blue Shield. As the
Tom.
payers look toward other payment models, do you think that the ACO payment model is one that we should emulate, or what would you recommend to us in terms of guideposts for making progress and conceptualizing the payment model of the future that would work for you to be successful with what you described today?
Yeah, I think it's very early in the game for ACOs. You know, when you really think about it, here's an interesting phenomenon. Like people say, well, ACOs are training wheels for Medicare Advantage, right? You heard that statement? Right? For those Medicare Advantage, where we pay people, Medicare gives the money to insurance companies, right? Interesting. So then I say, how much money did Medicare Advantage save CMS in the country last year? 0, right? They cost it somewhere between, I don't know, $4 to $8 billion because Medicare Advantage plans get paid more, right? How much did ACOs save? Well, they saved some, half $500 million to $1 billion, something like that. So it's an interesting policy wrinkle that we have right now. We're between Medicare Advantage, where rates are higher than fee-for-service, right? And ACOs, where they say, well, let's be stingy and only give you 50% of the savings, right? So I go back to the population health dividend. I said, and we said this in our recommendation, our responses to CMS, we think they should be leaving like 80% on the table. And they win with that. And it's very early in the game for us as providers to figure out what it takes to provide the kind of care management services to those populations. So I think it's early. Our goal is to contract with Medicare Advantage plans, with state government, with the federal government, with self-insured employers in ways that give us the incentive for delivering, for being accountable for the total cost of care and the quality outcomes. And we'll figure it out, and we are figuring it out. But so when you say the ACO model, I think there's the delivery system model, and then there's the financial model, right? And I think the shared savings model needs more work, frankly. And we're just learning on the delivery system side, I think, Tom. Yeah.
Thank you for your presentation. Kate Cohn-Parrott with the Greater Detroit Area Health Council.
Hi, Kate.
Hi. I noticed on one of your slides that you used the term patient, and I think there seems to be a push to use the term consumer versus patient.
Yeah.
I'm personally not comfortable with the term consumer because I don't think we're providing tools and transparency at the level for people to actually be healthcare consumers. I'm wondering if you had some thought process between choosing the term patient.
It's interesting. We went round and round on a little bit. First, we went round and round on should we be patient-centered, or should we be person-centered, or should we be people-centered, right? Or should we be consumer-centered? And we just settled on people because it sounded better, and it talked about numbers of folks rather than one. So that was point one. Point two was we've talked just recently again about this issue of a patient versus consumer. And for a lot of I guess what I'd say is, we got a good audience here. How many people would like, in these kind of contexts, be referred to as patients? Raise your hand if you'd like to be considered patients. Okay? And how many people would like to be considered consumers? A lot fewer people. Somehow, the patient piece, maybe, does it convey our understanding of the significance of the specific circumstances we are in when we access healthcare, right? So I'm not opposed to consumer, but I think somehow it feels like folks feel warmer, like patient is warmer than consumer, and so that's why we've kind of gone the way we've gone to date. Great question, thanks. Yes. Oh, I'm sorry. Go with the mic.
Hi, Mark Cohen, Blue Cross.
Hey, Mark.
So, hi. You had a slide up there where you had, the projection for costs going up this way, and your vision is you want it going the other way, curving down, and incentives going to, to the payer, to the employer, and to the provider. But who there's got to be somebody who's going to lose out. So in your view, who is the loser in this? Are the physicians going to be losing out salaries? And then it kind of comes to the question, who is your headwind in terms of internally within your own health system for trying to get those costs down?
Yeah, great question. Well, what's going to happen? Now the good news is I've been trying to get Gray to turn that iceberg on the bottom of under the water into a spinnaker. We got sailors here, right? You know what I mean? Because like that iceberg piece is actually, it's the lift that will be provided to healthcare systems because all people are going to do new joints and all that stuff, right? So if you really think about that coming along, right, there's going to be a need for a lot more health services. We can't afford to pay as much as we're paying today, and we need to get, or we can't afford to stay on the same trend line. But conceptually, there will be more demand, but if we do it with fewer services per demand, if you think about it that way, it's not clear that the losers are big time. Now, there'll be stranded capital. Does anybody from any industry other than healthcare know the term stranded capital? I think you have, if I'm not mistaken, $1.4 billion worth of stranded capital in this city, right? There was a number, something like that. Maybe it was $2 billion, right? It's all those automotive plants that aren't used anymore, right? So there will be stranded capital in the hospital side, right, that we need to think about. But there's also that lift coming as well. So I'm not sure I want to say losers, losers. I think we all say, look, we got to do something to make this manageable. We'll probably do less in the hospital. We'll need to, we'll invest less probably. But there are places where we're investing more in hospitals. There'll probably be less in the way of ancillary services, and they'll be done in different places, so we'll adapt to that. But we don't have like big active ogres of opposition. That's a good term, Gray. I have to get that down. I never used that before, right? We don't have those guys who are saying, or gals saying, no way. What we have is people saying, I got a lot to do and I'm busy. And I'll tell you, it's a pretty outrageous request we have, I think, of healthcare providers. And I'll say this in terms of nurses, doctors, people on the floors of hospitals and in doctors' offices. We're saying, provide more care, take care of all these people who are newly insured. We knew you were busy before, and you're going to even be busier now. And oh, by the way, transform the way you're delivering care. And spend time talking and thinking about redesigning care. It's a tall order, so people, we don't have a lot of active opposition. What we have are people who are saying, I got a lot to do, and this is hard, hard work. So that's what we're working towards. We've got a lot of working with, and that we've got a lot of folks who are committed and want to do it, and I think feel better. Because, nobody went to medical school, nursing school, hospital administrative school saying, I want to deliver fragmented, uncoordinated, expensive, low-quality care. Nobody did that, right? We all went into this because we wanted to do great things for our communities. We think this is a model that actually allows us to do great things for our communities, and we see our people getting energized by it. Yes? Okay.
Hi, my name is Tricia Walding. I'm with the Workforce Intelligence Network for Southeast Michigan. We work on behalf of the community colleges and the Michigan Works agencies in the region. And that was a great segue into my question because I'm wondering if you can speak a little bit about the potential difficulty of recruiting qualified talent and how that might impact the cost of healthcare in general.
Right.
In addition, what are your pain points regarding talent? What are some of the solutions?
Yep. So I know this guy. He runs a company called Iora Health. His name is Rushika Fernandopoulos. Does anybody know Rushika? Rushika just got a big investment from a private organization from private equity folks who said, yeah, we like your model of care. And it's the model of care to deliver primary care that's focused on population, right? And he hires all sorts of network care coordinators, navigators, people like that. What do you think his number one recruitment source is for people to work in that model? Where do you think it is? Nursing graduates, community college graduates, high school graduates, MDs. Best place to recruit Dunkin' Donuts. Counter people at Dunkin' Donuts. Because what is he looking for? When you really think about what it takes to do a lot of this new work that we're doing, it takes people who understand the community, who are empathetic, who are smart, right? Who are perhaps analytically oriented, maybe, who can engage with people and talk to people, and different kinds of people who are diverse, who come from different backgrounds, who can speak different languages or understand different cultures, right? And so when you say, you know, there's going to be a shortage of primary care docs, you know, maybe there's going to be a shortage of primary care docs. I don't really know. All I know is we've got to get out there and do the things we need, the work we need to do, and we've got to have everybody operate at the top of their license, right? And whether they're licensed or not, we need to train people up to be able to deliver the care and the services we need. Sure, we need great surgeons, and we need great OR nurses, and we need great people like that, and we'll keep getting them. But my belief is that if we get into a system like this, we'll think about sources of talent and kinds of people that we want participating in this that are very different from what we have done traditionally. So I think we need to do education. Community colleges are a great source of folks that will be somewhere in that, you know, in that segment for sure. And it's great that the work that you all are doing, I think. But we don't know the answer, right? And we need to discover the answer. One of the problems with having a tightly defined payment system that says, you want $35 for seeing a patient, you better be an MD. And I don't care if you're, you know, looking in their ears or telling them whether or not to eat orange or feed the baby orange or green vegetables first. $35, you know, and you need an MD. That's craziness. We need a system that allows us to make the right judgments as we operate our business, not from Washington, but in our local communities. So that's why I think changing our payment models, changing our clinic models, we'll find out what new and different kinds of folks we need going into our healthcare delivery systems. Okay? Thank you, Ed, very much. Thanks.
Thank you so much.